My name is Michelle Pryde, and I'm a Master of Applied Science student in Biomedical Engineering at Dalhousie University. Image-guided diagnosis of acute ischemic stroke via CT is standard in emergency medicine, largely due to its rapid image acquisition. However, it's known that MR yields superior contrast for visualization of stroke, but its application to diagnosis is largely limited by long image acquisition times. Accelerated image acquisition is therefore key for image-guided diagnosis of acute stroke, but yields degraded image quality. Image-guided diagnosis of chronic stroke is also clinically important, but does not share the same immediacy for treatment as acute stroke. Although supplementary information on chronic stroke would not affect acute stroke treatment at the point of care, being able to concurrently identify both acute and chronic stroke from accelerated MR scans is beneficial. Therefore, the aim of this study is to evaluate diagnostic utility by investigating whether a reduction in image quality impacts radiologists' clinical confidence in reporting acute ischemic stroke most importantly, but also chronic stroke in tandem. Data were acquired from 16 patients with suspected stroke and 2 healthy volunteers. For all stroke patients, research scans were always performed in addition to standard of care. All recruited participants were scanned on the 0.5 Tesla MRI system under Nova Scotia Health REB-approved protocols. Our clinical team is focusing on the FLAIR and DWI acquisitions as a low-field rapid stroke screening exam. Since the FLAIR acquisition is much longer, these images were retrospectively degraded by compressed sensing undersampling and reconstruction. All FLAIR images alongside corresponding DWI images and ADC maps were shown to 3 board-certified neuroradiologists who were individually asked to report the presence or absence of acute stroke and Physicus score for chronic stroke, ranking their clinical confidence on a 5-point Likert scale. Inter-rater reliability was calculated using quadratic-weighted Goetz AC2. A one-tailed Bonferroni correction was then performed to determine if neuroradiologists' clinical confidence scores for compressed sensing accelerated images from R equals 2 to 7 times were statistically significantly different than non-accelerated reference images at R equals 1. Results are shown in figures and tables here, and worth pointing out is Figure 4, which shows neuroradiologists' average clinical confidence scores for acute stroke in the left graph and chronic stroke in the right graph, each plotted versus the compressed sensing acceleration factor. The images below each graph are example images from a recruited stroke patient. From the Bonferroni correction, it was determined that image acquisition time on this head-only point-of-care 0.5T MRI system can be significantly reduced retrospectively from about 4.5 minutes to 38 seconds at R equals 7 times without impacting neuroradiologists' clinical confidence in image-guided diagnosis of acute ischemic stroke. For chronic stroke, however, clinical confidence was statistically significantly different and therefore impacted starting at R equals 3 times. Lastly is future work, references, and acknowledgements shown here. Funding for this research work was provided by Research Nova Scotia, NSERC, Brain Repair Centre, and Dalhousie University.